Welcome everybody to Informed Choices. We're going to talk about improving contraceptive outcomes for women and having meaningful conversations between patients and physicians or healthcare providers. So today we are here because of the Rowan Foundation and their amazing support to a specific cause. So first of all, I want to talk about modern contraception, and I'm going to start quoting modern contraception because contraception as we know it nowadays has not really evolved much from what it was 100 years ago. And if we go back in history, we can find thousands of years of barrier methods and other forms of natural contraception, if you will. But it was 60 years ago that female oral contraception began a revolutionary statement that was very well adapted within society. So once that became popular and available to the masses, the global fertility rate decreased from 5.0 in the 1960s to 2.5 today. And in part is used to new contraception practices and also because of the education that has become more available. However, I think there's still opportunities for us as higher ed institution and as public in general to advocate for the inclusion of more education surrounding women's health, not only reproductive rights, but also fertility and how general female anatomy works. I think those are topics that we do not include on our daily basis education, and they should be as important as anything else that we learn in school. So advocating for higher ed to have programs where we include contraception, fertility, and sexuality should be on the agenda of any major higher education institution as well. How do we empower young women and young men to make decisions about what their future sexual fertility journey will look like? Now, since on the past years, we've had a different change in the landscape with different legislation, but we also got the introduction of other contraceptive methods, not only oral and barrier methods, but other choices that can provide young women with more flexibility and also that can adapt to the needs of specific women and their medical history. However, I do believe that these options have not been brought to the attention of the general public. Hence, there's a belief that there's limited options still, such as the pill, condoms, or other methods that are very communicated through either social media and other channels. And us as educators, we tend to rely on those because are the easiest ones to access, and because they are the ones that we've historically understood. So I think there is a lot of room to explain what is new and how can that be suited for different women and what their aspirations and what their life will look like. I think contraception should be individualized and not treated as something for the masses. Mm-hmm. But as doctors, not often we get the chance to have patients asking the right questions. So that's another thing what we're here for. What are those questions and what can we do as providers and as public and as people who faces communities to help bring awareness of the right conversations that need to be had once young women come face to face with their providers. I am going to start asking about access and availability. what do we think is out there? What do you think is available? And what are the barriers for contraceptive access? And we can talk about everything: cost, geographic limitations, healthcare infrastructure, and overall, whatever we consider a barrier for young women to have access to, I'm going to call it successful contraception. And successful contraception can be individualized, because what's successful for one specific woman with specific medical history is not going to be the same for another one. So, Toria.
Since I work directly with students and the community and things like that, what tends to come up is we have to address some folks lack transportation. And then because they are lacking their own transportation, sometimes they might need to rely on maybe the bus or maybe ride shares like Uber and Lyft and things like that. And as we know, those things cost. And sometimes that's also an additional barrier, folks just not having the funds to cover those types of things. And of course, that can be discouraging when it comes to seeking that care and things like that. And then kind of to your point earlier, addressing that each person is different and each person has different types of barriers and things like that. So it's important for us to be mindful of the experiences of different people. So when we think of disabled folks, there's additional barriers such as, like I said, the transportation, or when they actually do get to the doctor's office, sometimes accessing or getting into the building can also be a barrier. So when we think of people who are trying to access these things, it's important for us to be mindful of what's the journey it takes to get to us. Different people are experiencing different things. And so, yeah, that's kind of what comes up for me at this moment.
Thank you. So, Dr. Al-Khatib, I know you work with a lot of students around mental health and mental health issues. So, what are the barriers you perceive, especially with a very diverse community that we work with, as far as having access and available resources?
So from the mental health perspective, I service students who suffer from depression and anxiety. And we know that these two mental illnesses are among the leading causes of actually disability in the US and in the world. So whether diagnosed or undiagnosed, they don't have to have the diagnosis, just having these symptoms. And they can get in the way of actually making informed decisions. We know that depression affects the level of motivation to ask the questions. If someone is suffering from depressive symptoms, they're not motivated enough to ask those questions about risks and benefits of choices available to them. Anxiety leads to avoidance also. Some of the students that I service are so anxious that they avoid the topic. They don't want to talk about it, even though they are in relationships and they are sexually active, but they just want to avoid it. So it's very important to kind of have this therapeutic rapport with the patient or the student and have that discussion about a holistic approach to these things. And this is where I start usually in the clinic. Of course, I prescribe medications, so this is also another discussion because I want to make sure they're taking medication that doesn't affect any of their hormonal treatment, or if it's contraindicated, or if it's not contraindicated. So we have these discussions. And what I find has been helpful to my students, the students that I service, is mostly refer them to a specialist before they made up their mind about oral contraceptives. And I encourage them, just talk to the specialist. This is not to push you to be on any method. Just have that discussion in preparation for future. And a lot of the students do that, and they like it. They like doing that. Just having a consultation without the pressure of having to make a decision at that point. Yeah.
So I think that brings us to a little bit of the role of a doctor, a healthcare provider, as an educator. Because I think often we think about ourselves, providers, as fix doers, more in that let's move to action sort of space, but we do not often have the time to sit down in front of the patient and bring the education piece. And I think that's definitely missing in the way we practice medicine nowadays. And it definitely affects and it can bring biases to the patient because they can see when we don't have the time, when we don't engage in conversations with them, and that might significantly affect the decision that they make. So, Dr. Wen, what do you think is the role in comprehensive education and campaigns in improving contraception knowledge in young women?
Well, it's definitely a loaded question. I think, as healthcare providers, we should definitely address what you're bringing up. What can we do within the four walls of our exam room? And then, I want to address like what happens outside of the exam room. But I think within the exam room, average time outside of a student health center is really about 6 to 7 minutes with these patients. Thankfully, in different environments like here, we have much more time to do the education piece. But you're right, it's not necessarily something that we're trained to do well. But I think we could do a better job of at least calling out that there are other resources. If we're not the ones directly telling the patients about all the options, there has to be trusted resources that we're guiding them to. I think the challenge that I've seen is that when we don't do the education, there's a gap. And then our teens and young adults, they're curious and they want to be healthy. And so they go seek other resources. And those resources sometimes can be valid, and a lot of times they're not. And so you think about social media, you think about Google, TikTok, all of those resources to them, they have gone to seek because we haven't provided them with what they need. And so I think that's really important for us to think about when we think about how we're going to bring healthcare providers up to where these young adults want it to be, like where they want us to meet them. We have to think about what we can do inside the exam room, but also what are we doing outside of the exam room.
Toria, what is your perspective when you talk to young women about education and awareness? Do you think as a society they are aware of all these different contraceptive methods that are available? Or do you actually find that they come to your spaces with something in mind?
Yeah. What I find is I personally think that students are not well aware of what all of their options are. I honestly can think of like interactions I've had with students directly where we've had conversations and it was very clear that they're just not quite sure what's best for them or how to move forward in like their relationships and things like that. And so like with that education piece, and to your point, like students could benefit from having like that safe space to have that conversation about like sex education and like including in that the conversation of contraception and also like adding in that extra layer of bodily autonomy. I think students, or at least the ones I've interacted with, I think they're not quite like they don't understand that like their body is their own and like you can make decisions that's best for you. And so like helping them learn that you can like trust yourself and trust what's best for you in your situations and things like that. Like helping them learn is important. And yeah, I think we could enhance with the educational piece.
I want to circle back a little bit on that last comment. So you think there's some elements of social pressure, peer pressure, or what other friends might tell you, like, hey, just go get on the pill, go buy this, go do that, surrounding young women?
Yeah, absolutely. I've seen it. And then to add like that extra layer to that point, because oftentimes in our office, we are also speaking with students who are in unhealthy relationships. And so they're in their relationships, like, there is that pressure of like either you shouldn't get on birth control, like that force of not getting on it, or like they are being forced to be on birth control and they're forced to do something that is probably not good for them. So again, like, I think to that point of like education and teaching students or young people that like you do have a choice in the matter, and like, whatever that looks like for contraception, like you get to ask questions and you get to choose what works best for you. So yeah.
I think that's definitely a point to consider, especially when it comes to young women and how we get influenced by people that surround us and by social media nowadays. So I think that brings us right into the next topic, which is cultural and social influences. Do we have societal norms? Do we think that society has somehow ruled how contraception should look like for women? Like, like how in the 60s the pill was revolutionary, so it's just the way to go. Or how other methods of contraception came in different decades. Like, I remember when first IUDs, like when we look at literature and the first IUDs came up, and there were so many complications surrounding them. So how do we feel about societal norms, religious beliefs as well, and the stigma around contraceptive use? Because in this very multicultural society that we live nowadays, your access to information is not the same as my access to information, and that's our reality. And we need to talk about it, because we will be delusional if we think there is not different levels of access and different levels of conversations happening within our households. Where do you see the societal and cultural influences playing a role, Rania?
I mean, it's just very obvious. Like, we are social beings, right? So we operate within the context of our society, the social framework, also with the psychological framework. But most importantly, it is the conversations should start by individualizing the encounter. Like, what is your challenge? What are your thoughts about contraception? Make it more general and then narrow it down, because we don't know. Every patient is different, and every patient is different in terms of what they perceive as a stigma. In my conversations with my patients, I try to stick to the facts, but initially I have to pinpoint where is their challenge. Some of them it's religious, some of them it's just the group of friends they hang out with. Some of them it's they don't want to look poor, that they cannot afford. Yes, some of them have lack of financial resources. So being able to first pinpoint their own challenge and then go to the stigma part, this is where I find I spend most time when I talk to my patients. Yeah, but I mean, definitely I've had international students on campus, right? And they come also from different set of in societal norms. And luckily we have many providers in the clinic, and they're diverse too, and I can try to match the diversity with the diversity of the providers, so that helps. But this is how I start, by addressing it.
What do you think is your experience as a provider when you see different young women from different backgrounds? What's the differences that you see in the education and the information that they have? And do you see a trend in certain like group ages or certain specific demographics or so?
Yeah, definitely. And some of it hasn't really changed over 15, 20 years, which is, surprising in some ways, but then not, because I think our system, our healthcare structure right now does not allow our clinicians to individualize as much as we want to, because we know that's what's needed. Our information and education is very general. And so when I have patients who I can think of are my teen patients who are pregnant, I always ask, what led you to this situation? Like, how can we do a better job? And it's not uncommon to hear that in my household, we don't talk about contraception. We're not allowed to ask about it. It's not uncommon to hear from teens who are pregnant that, well, all of my friends said that I would gain weight if I got on the pill. And so the gap of not knowing that there are other options outside of the pills reinforces like why we're here today, right? Because it doesn't have to be the pill. And there's certainly other options that we're going to be talking about later that don't necessarily have the same side effect profile that is sort of demonized on TikTok and in a society that is so focused on body image, that we want to be able to educate our young folks that you want to consider all the options. You want to make sure that those pros and cons lists are actually, valid to your beliefs and not just like everyone's.
Toria, I want to include you on that because you face a larger side of the young women community here. What do you think, or what would you consider is the access to contraception education that they've had?
Yeah, I think kind of like echoing what everyone has said, I think the young folks that like come to our space, they're getting a lot of information. Some of it's misinformation from like social media, from their friends, and they're lacking the true information from like their families. In their households, they're not talking about it. And again, thinking about like my one-on-one interactions with some students, like I've learned that also there's like a level of shame with it too, like the shame of not knowing. And then there's also the shame of like they do know and they're like, pushing themselves against the whole idea of it. And again, I think that's linked to whatever information that they're getting from like their social groups or, social media and things like that. So yeah, I think to answer your question, like, I just want to emphasize what y'all were saying is like, that's what I'm seeing as well. And like with my role, my job is just to like provide that education and also reassure to them that it's okay that you don't know. A lot of us don't know. And so that's okay. But here's, the information that's out there and you are more than welcome to like think about it, talk to someone and make the decision that's best for you.
I would like to add something on the educational part. In our encounters, we always I personally focus on obtaining a thorough family history. Mm-hmm. And sometimes the students don't know. They tell you, oh, I don't know. And I'm like, okay, so is it okay if you give me consent to talk to your mom or dad about what kind of things run in the family? Sometimes they don't want to because it's then I'll give them the questions. Yeah. I say, hey, how about you go back and talk to your mom and dad and ask them these questions? Because many of them don't know that the families, they'll tell me, oh, they have colds. Mm-hmm. They were hospitalized, I don't know what, too long ago, I don't know why. Stuff like that. And I think that's very important.
Yeah. Yes. I think that's a part that we don't talk about very often as providers. Mm-hmm. We do not offer education at a young age so that young people can talk to their parents or relatives if they don't have parental figures around about family medical history. What is been going on with my family? And it can sometimes it can go generations back. Mm-hmm. So you no longer, it's not only that you need to have your parents' medical history. What about your grandparents? Mm-hmm. Were they all of their pregnancies were successful? Mm-hmm. Did someone die during childbirth? There's like so much to ask, and we don't really educate young people about asking and having these conversations with their parents about history and about cultural background. Did you had a surgery when you were young? was everything okay with that surgery? Do you have complications? I don't really think we encourage young people to look back on generations about their health. I think we're doing better about looking back on our traumas, but we're not doing better about looking back on our health history and past medical history of our parents, their siblings, and other generations that precede them.
I think it's also important to think about, like, from a cultural standpoint, some families, and I know we'll probably talk about it later, but some families have like a rocky relationship with like the medical system. Therefore, like maybe your father probably never went to the hospital or never went to the doctor, and he probably doesn't know about his medical history. And so, or like grandfather or grandmother probably don't know. So I think it's like another layer to like include. And so, because like sometimes folks, maybe they want to ask those questions, but they know that like their family's perspective on medical care might be like a little rocky or maybe misinformed or something of that nature. So yeah, it's like, how do we navigate that too, like within those cultural norms, I guess?
Yeah, that's a great question. I'm gonna defer this to the both of you. When you see a young person who does not know or necessarily does not have the background and is about to engage on long-term treatment, what do we suggest there as providers? Do we talk about genetic testing? Do we talk about digging a little deeper with clinical analysis, labs, imaging? Where do we start?
I think some of it is what you've already covered, which is encourage them to ask. And I think it depends on the situation. I had a student who mentioned that her mom had passed away from breast cancer. And so the next question is, do you know if she had the BRCA gene, which is a gene that can increase your chances of getting breast cancer when you're older? She didn't know. So in that situation, we were able to talk about her getting tested for the BRCA gene. So I think every situation is different. However, it really is about empowerment. Really, it seems like what we've all been saying for the last 30, 45 minutes is, how do we empower the student or the young person to be curious about, my mom did pass away, so what now can I do for myself?
Yeah, and empowering the student or the patient, the way to address that specifically in the student population, because most of them value privacy a lot. They say, well, it's a private information. I don't like to ask my parents question. Then reframing that into that this is actually baggage that you carry and you need to know about it. It's not that you're not being respectful to the privacy. And we try to reframe it. And it takes sometimes more than one meeting. They'll come back saying, oh, I forgot to ask. Okay, so can we set a reminder on your phone so that you can remember next time? Because it's really very important that so you know what you're carrying, your baggage. So, but empowering is very important. And we do this with motivational interviewing, which is also an empowering technique.
Can you talk a little bit about that?
Yeah, so the motivational interviewing is mostly led by the patient. So I would, for instance, if a patient doesn't know, and I'll go, for instance, so what would it take for you to know more? Tell me more. What would it take for you to maybe take an extra step to know more? I'm not saying you should do this. I'm not saying, why don't you do this? I'm saying, what would it take for you to find out more about it? And then the student or the patient is thinking, maybe I can text my mom, or maybe I can, when I go for spring break, have that conversation. So it's led by the patient, by the student. This is more, I find it more effective, and the evidence shows that it's more effective. Yeah.
That's makes me think about the willingness of all of us as providers to go to those lengths. And I think that's something that we should definitely keep pushing for the medical school's curriculum to include. How do we engage in meaningful conversations with our patients. Because I think the medical school curriculum sometimes does not encompass that side of it.
Right.
Does not encompass a lot. They never teach us how to charge, right?
Exactly.
So that part. But they never teach us how to talk to patients. And I think there are just parts of it that are lacking. And it requires providers as yourself to have the willingness to engage in those conversations, but not everyone does. And sometimes it doesn't cross your mind
Yeah.
to have the conversation or to redirect it, especially with young people as you do. So I want to talk about the innovations in contraception because we talk about what's been there forever, right? We talk about when you think about contraception, the only thing that I can come up with for the males in reproductive ages are condoms and vasectomy. But then everything else goes to the side of the female in a reproductive age. So that is a lot. That is a lot of pressure for females to keep on top of what's new.
Yeah.
So tell us a little bit about the innovations and what their potential impact could be for women's health in the years to come.
Yeah. There's definitely needs to be much more focus on different types of contraception for all genders. I think that they're lacking funding for that. If you think about, if there is innovation in different types of contraception for males and females, what that does just on a cultural and societal level, like you were alluding to, is like, why is it one side carrying the burden? If it should be inclusive and accessible to anyone who wants to be the person to manage that. I mean, it's not, it's part of our routine that after we see a mom for a delivery to ask immediately, how's your breastfeeding? Okay, what do you want for birth? What do you want for contraception? It's like, there's so much burden there. So I would say that's one piece where funding and more research can really help. I've looked, and there are some institutions really looking at some great options for male hormonal and non-hormonal contraceptive methods. I hope to see it in our lifetime, but these things take a long time. I even saw that in Boston, they're working on a non-hormonal patch for women, and so I think we're just right on the edge of people wanting to see the options. And we just have to keep pushing. And the awareness is really important, because otherwise we don't go and look to help support these types of innovations that really could be life-changing. Since right now, our options really only have a few really effective non-hormonal options. And so what would be really nice is to have more of a balance of the non-hormonal with the hormonal options, also for both the female and the male.
Mm-hmm. I think the part of distributing sort of the load or the weight of contraception between male and female and having a wide range of options for both of them, hormonal and non-hormonal, it's definitely going to be the key so that we can start seeing a bit more of equity, if you will. So I think one of the things is that we need to talk about, and we've been talking about this during our conversation, the healthcare provider training and support. What do clinicians need, or how can they be educated to have unbiased contraceptive counseling? How can we do better as providers in offering all of the choices without having that bias about, maybe I like this lab, I like this pharmaceutical because they're convenient, they always take my calls, they always have a rep available, or I've worked with this contraceptive method for so long and I've had good results with it, so I'm just going to offer this. How can we reshape the way we approach it as clinicians to make sure that we advocate for our patients by providing all the choices available without taking our own biases into consideration.
So I think it starts with having a generous listening time, listening to the patient and to their specific needs. And by generous listening, we mean be non-judgmental and open to what the patient is bringing to the encounter. And then after that, basically exploring the data, knowing the facts, the science, being familiar. I'm not an OB-GYN doctor, but I'm sure Dr. Wan will comment on this, knowing the facts, knowing all that's available, and spend the time educating the patient about all the available options with a thorough discussion about risks and benefits, like any other intervention. That's, I think, I don't know what you think.
Well, it's very complicated. I think I would say it goes back to really empowering the individual. Because if you look at the way our healthcare system is and the way our training is, that change is going to take so much. I mean, in medical school, the 4 years, it's packed with information. So it's not that we have downtime, but it's not packed with everything that we need to be a successful and effective clinician. So then we have what? Then we have CMEs. We have continuing medical education that we have to do to maintain our license. But even, as we do that once a year, it's like we're just trying to find time to do it. And most of it is on new treatments or new things that we need to keep up with. And so where does that leave us room to then also learn about how to communicate with our patients better, how to check ourselves if we're having biases or judgment? Where will we fit that in, right? And so if we could empower a patient sitting in front of us to question what we do, then, I've definitely had moments in my career where a patient will say, well, are you sure that's the only thing that you have to offer? And then I'll have to pause and be like, you know what? Let's come back to this. Come back in a week. Let me do some research on it. And so if we don't, there's this balance between having the patients really feeling empowered so that they can keep us in check. I think too long we've had this tradition where the clinician has power over the patient. Yeah. And I think that's really put our ability to serve the patients, which is why we went into this profession in the first place, is putting us at a disadvantage.
Yeah. I think hearing that, especially young women, whenever they look someone on a white coat, they're definitely looking for answers. So we definitely, as a system, need to do better about presenting all the options. And I think it doesn't stop with providers, clinicians, physicians. I think the healthcare system overall should be open to have this conversation. Because as we know, sometimes a young woman creates a better rapport with the nurse that has the patient come in, takes the vitals. It's the first face they see, ease them into the exam room. So I think it's a job or an effort that should not stop with clinicians, because we are the last barrier. We're the last thing that the patient sees. But a young woman looking for contraception will first make an appointment on our website or in whatever platform that we have. So how are we promoting meaningful conversations since the first time we encounter those potential patients? And then, so they come in and then they see our front desk staff. How are they encouraging to ask the right questions? And then we have the second layer, right? The nursing staff and the lab technicians and everyone else who does work around it. And sometimes the patients feel more inclined because they don't seem as scary as the white coat behind all the doors. So they might feel more inclined to ask them their doubts. And what they say is, you need to ask the doctor because I'm not qualified, I'm not licensed to answer your questions. What are ways in which all the healthcare system can answer those questions or can lead the patient to ask the right questions once they reach the last barrier, which is that white coat that may have all the answers, but I just don't know how to ask. But I think that's, it should not just fall on the physician. I think, what are we doing to encourage that engagement from patients from the beginning?
Yeah.
So let's talk about disparities in access and the use across different socioeconomic, racial, and geographic groups. So the latest statistics show that because of many of the major changes in legislation that have happened over the last few years, mortality rates have increased around delivery and maternal control on the Black population and Hispanic population. Also, unwanted pregnancies have increased in those two populations, especially in those states who have changed regulations. How do we address the disparities and the different accesses across the different groups? Toria?
Yeah. Side note, this is my favorite thing to talk about. And so I think it's fair for us to admit that, like, when we think of reproductive health care or when we think of contraception, I think we have a certain image in our mind of, like, what that person looks like, of, like, receiving those things. And when we have that image in our head, we're forgetting about everyone else. So we got to think about, like, the marginalized populations, such as, like, the Black population, Indigenous folks, disabled folks, the LGBTQ plus community. Like, oftentimes they are left out of, like, these conversations, right? And so I think when it comes to, like, addressing those disparities, I think it's important to recognize the trauma that they have with the medical system. Like, for example, like in the Black community, I think of Fannie Lou Hamer, who went to the hospital for one thing and left she had a hysterectomy without her permission. And so, these are the like, that's the thread that's going through these marginalized communities, like that trauma. Like, if I go seek this type of care, like, are they going to take my choice away? Like, are they going to give me the right information, or are they going to try to, like, lead me to basically do this one thing that I wasn't trying to do? And then I also think about, like, in the disability population, it's kind of similar, where in that population, the common idea that the view of disabled folks is, like, they're not sexual beings. So therefore, why would they need to seek out birth control or contraception and things like that? So oftentimes that conversation gets dismissed when they are presenting that to their doctor. So I think it's important to, like, address, like, that history and kind of, like, what we discussed previously, like, discuss, like, the societal ideas that are placed on these marginalized communities, and also, like, what message is that sending to these populations? Like, for example, with the Fannie Lou Hamer, like, what message is that sending to her and to the other Black folks who are seeking care? What that message is essentially saying is, like, you don't deserve these things. Like, you don't deserve, like, this health care, or you don't deserve, like, a positive experience. And to take it even further, it might send this message that, like, when it comes to like, reproductive care, like, you don't have a choice. I get to make that choice for you. So I'm saying, like, that's the message that folks are receiving. And so when they're seeking out care, like, being mindful of that and, like, kind of challenging that message that they're having. I hope that makes sense. But yeah. So
Absolutely. I see it as am I going to go and have my medical decisions made for me because I'm a minority or because I don't ask the right questions? And how could that change the dynamic between patient and provider? When and there's such a thing as obstetric violence, and then we don't want to get too deep into that, but when you impose a treatment over a patient, or when you make the decisions for the patient instead of inform them so that they can make their own. Ellie, what do you think your experience has been with the different geographic, ethnic, socioeconomical groups that you've served?
I think there's definitely layers. And so if we just even pull back and look at physical, like equity to access in rural areas, that's, a problem. There's definitely deserts, got what they call contraception deserts across the country. And, certain states have very, very limited, not just education, but actual options that they're offering, depending on the regulations of that state. They also put some restrictions on minors and the ability for minors to access contraception without their parental consent. And so you see a variety of that. You just look from, west to east across our own country of access, physical access. There's inequity there for sure. And then, I think definitely the things that you mentioned and around our society's tendency to label and to stereotype about what we think you need is always, a problem that I think in recent years have come to light more, but there's still so much work there to be done.
I think I've never heard that term of contraception deserts.
Yeah.
And it's kind of hard to hear, but it is a reality that there's geographic pockets where minors are not allowed to make their own decisions about contraception. And people overall have only limited choices. And it's very, very hard to wrap your mind around it, being 2025, having specific places within the country where it's either this or that. So what do we do if none of that fits the patient's needs and medical history, right?
Right.
So we've been talking a lot about access and education and what needs to be done to open these dialogues about different contraceptive methods and women's reproductive rights and health. But I believe one of the most important pieces about making the right choices is making informed choices. So I want us to talk about the different contraceptive methods that we have available today and where do they stand as far as effectiveness, practicality about them, and how can they be suited to specific lifestyles. And we will for sure talk about hormonal versus non-hormonal. And I want us to start with long-acting reversible contraceptives or LARCs versus the short-term methods, if you will. So could you give us a big scoop about evaluating effectiveness, the accessibility, and what do you see in the clinical practice as far as patient preferences?
Yeah. We're lucky that we do have a wide range now compared to, 20, 30 years ago. And so when a student comes in, I'm able to ask, what's motivating her to even want to talk about contraception and go through the different options, which are, from barriers to pills to injections to, the longer acting ones, which is the implant in the arm or the IUDs. And so we can go through those options. And I think, again, in this environment, we have the ability where we can find out what's going to be the best for that student, given the pros and cons that she's looking for. But in other environments across the country, that's not always the case. So even though we have these as options, not every health center has access to these options. And what that means is that leaves the patient with very limited options, depending on what state they're in, depending on if they're rural or urban. Even within the urban environment like here, different organizations will have different access. And so that really goes, again, back to really having the patient and the student understand what their options are. And for our providers to also be aware, like if we at our organization don't have certain options, we should be able to give resources to our students and patients on where they can go, even that if that is 5 minutes down the street or, down to another organization. I think that's where we start to see that patients will get stuck sometimes because they are wanting the convenience of being able to go to somewhere close. And if that particular clinic doesn't have those options, they then just limit themselves. And so patients, I think, are very surprised still, even to this day, even though IUDs have been around for 10 plus years, to know that IUDs come in two different forms, that they have the non-hormonal versus hormonal option. And so we get to spend time talking about it. But again, it gets to the point where once they decide and they don't have access to it, then it's very easy for that to become a barrier for them.
I think this is such an important piece of it, with IUDs being not new to the game, if you will. They've been around, but there was some misconception around them and about complications, especially with the non-hormonal ones. And I think as we've evolved as physicians, clinicians, and as the science behind the IUDs has evolved, communication of the evolution has not been successful.
Yeah.
So some myths about what the IUDs were at the beginning remain. How do you feel like you address those myths and those perceptions within your practice?
I think the challenge is we don't really have a good venue of distribution of that type of information, right? So you're saying we've learned so much from the first time the first IUDs were placed till now, but if you think about it, how are we getting that information out? And so when the students come and I talk to them about the IUD, they're like, oh, no, I don't want that because I saw in that TikTok video how painful it is. And so that's their reference, but that's not their fault because we have nothing else for them to go to, right? And so if we could share with them through our own videos, our own, ways to say, look, that could be true, but these are the things that have evolved over time that have changed so that that's not necessarily the experience everyone has anymore, and that this IUD that has no hormones could really be a good option for you. So definitely a gap there.
Toria, I'm going to ask you to contribute on this a little bit. How do you feel the younger female population consumes information regards their medical care the best? Like, what will those channels be? If we were to talk to physicians, providers, pharmaceutical companies about where are we falling short on promoting the evolution of these contraceptive methods, how do you see our young women consuming that information?
Absolutely. I don't know if it's cliche to say this, but I think utilizing social media is a good tool because that's, like you mentioned, that's where they're getting that information from. That's like a safe place for them, I guess, is to just go straight to the internet, basically. So I think taking advantage of that, and I've seen some things where I've seen some physicians, they have a TikTok page and they are literally addressing the concerns that people are having on TikTok. And I think another method is I'm a strong believer in meeting people where they're at. And so if you can somehow get to them in the community, get to them directly, and having those conversations is also helpful. So holding workshops or this kind of setting, finding some way to get to them in the community and just showing your face and letting them know hey, any question that you're having, we're about to address it right now. I know with young people specifically, they really like to have a person attached to this, the information. So if they can identify okay, this is the person that I spoke to, and like they talked to me directly. If I ever have if I ever have questions later down the line, I can go right back to this person and just like seek some information. So I think that's a method that folks can try to utilize, is like, instead of I guess having this expectation that folks will come to you, maybe just coming to them directly in whatever space that is comfortable to them.
I think what we see in social media is a lot of plastic surgeons,
Yeah.
a lot of dermatologists. So we do see that that specific sector of the healthcare providers have identified where the young people are and how to talk to them. But I think psychiatry, OBGYN, primary care, surgery, we have not successfully managed that transition into becoming some sort of influencer.
Yeah.
Because it's not sexy.
Yeah.
It's not attractive to talk about what we provide. It's more attractive to talk about what makes you look better, right? But I think we definitely, as providers, need to make a little bit more of an effort to sort of step into this influencer era, so to speak, and then just meet the young people where they are. So let's talk about managing the side effects and improving patient satisfaction. And this is a very tricky one because sometimes patient satisfaction can be also utilized as a weapon. You know, like, I'm going to rate you as a great physician if you give me what I want. Or I need to please my patient or my student so that they can give me a good rating regardless of, is this the right treatment for them? I think in an era where people talk to each other more than ever, and then we see all those ratings about doctors and all those Google Map stars, we often feel a little bit more pressure about patient satisfaction. And I just want you to address common concerns. How do you make sure that you have a positive contraceptive experience? I'm going to ask you from the provider standpoint, and then I'm going to ask you to step in from the user side of this topic.
I mean, I think, you know, when we think about us being a user or a consumer of something, like, one of the more satisfying feelings is knowing that you have the information you need. And so I try to approach it in this way, is that ultimately whatever decision the student makes, that they feel informed. And if they're informed, then I can only hope that that's enough for them to feel satisfied with the service. And, you know, you can't think too much about the star ratings and all those things, because it really does take you off of like what our goal is as a trusted, you know, clinician for our students. And so when they come in and they ask about whether it's contraception or testing, STI testing, anything like that, is giving them that information of all the pros and cons that you can provide with each method, and then really pushing it on them to say, look, you don't have to make a decision right now. You can come back next week and we can talk about it. And then I found that giving them an out is also a nice way for them to feel relaxed. So especially with the short-term methods, we can always stop them. You know, like there's no reason why, if you make a decision to start something, that you have to stick with it for an X amount of time. And it seems so obvious to us, but when I say that, I can see them physically be relieved that, oh, I can stop that pill, or I can stop this if I don't like it. And so really goes back to empowering the student, is that they have a choice, and that ultimately, as long as they have the information that's correct, that they should feel like they can make that choice on their own.
Yeah, I was gonna say I agree with what you said, and I was also like, as I was thinking about the side effects and the patient satisfaction, what comes up for me is I think about, like, I'm now thinking about my old role when I was working with survivors of, you know, harm and things like that. what comes up for me with this is sometimes folks are afraid to like even have these types of conversations, and they're also afraid of like what could come out of these conversations. And I think all of that is related to their traumas, and then also like the misinformation that's out there. I think it's both of those things happening at the same time. But in my experience, I've dealt with young people who were just genuinely like afraid of like are they going to do a pelvic exam? Are they going to do this? Like, are they going to put something inside of me? Like, I'm scared, all of those types of things. And so I think it's important to like consider like that fear. And then as it relates to that patient satisfaction, like once, like, obviously we want to create a safe environment for all folks who utilize medical care, but that to enhance it, like addressing that fear, like, like this could be scary, especially because you don't know what you're expecting, and just like validating that for them will probably like just enhance that experience for them. So that's kind of what comes up for me when I think about this.
With my patients in the psychiatry clinic, I always start with a very direct approach because it makes it non-judgmental. And I'll just say, have you ever had a formal education visit with a provider about sex education and contraceptives? Just very simple question. And they'll pause. Some of them say, well, my friends told me. I'm like, no, I mean like if someone who's trained. And they'll say no. And then I refer to the providers in the clinic for just education visit. Just for education visit, and they like it.
Well, I think that's an important part, is normalizing what you said earlier, is that there is a shame about why am I 22 and I don't know about this birth control, for example. Well, it's because our system never taught you, and it's not your fault. And so just normalizing it, saying like, why would you know? It seems to really help them. Like, why would you expect yourself to know something that no one's ever taught you? And so that really helps.
And I think I'm gonna go back a little bit on what Toria said, and hearing you out about the anxiety to have a pelvic exam as a young woman for the first time. I think it's important to walk them through expectations, to talk to them about expectations, and being very transparent about this is how it looks like. What is your experience when young women come to you and you approach, pelvic exam might be a step for you to get contraception?
Well, I think the trust has to be there. And so in a lot of ways, because of the patient population we're serving, a lot of times it is their first. So throughout a day, I might have several first exams. But I found that if we do take a little bit of extra time to walk them through the exam, teach them how to breathe through it, and show them like the speculum, it's all done in a way where once it's done, they're much more comfortable with you, and it really opens this door of a long relationship, I hope, where they can come back and talk about any issues that they have, in contraception or not.
As you've embarked a little more into this population of a younger patient, what do you think are youth and adolescent contraceptive needs? How can we, as educators and as providers, create strategies to improve contraception and access to different methods around young people?
Oh, gosh. I think, it doesn't necessarily intuitively attach to the idea of making contraception accessible, but it's something that we've talked about for several months, is around making the health center accessible. Many of the students I speak to will say, yes, I've been having unprotected sex and I've been thinking about birth control, but I just didn't know where to go. And that sounds so alarming because you can find it in so many areas, but it's really that is sometimes the most common answer I get. It's like, well, I didn't know you all were here. Or how do I get access to contraception if I know my parents don't want me on it, or just to even learn about it, I'm not allowed to ask. And so I think one, low hanging fruit potentially, at least for us locally, is how do we get out to these students here, just outside these doors, to know that we're here. And then once they know we're here, then what? Then it becomes more of something we can control, which is the information we give them, the time we give them, the safe space that we give them. But there are, I think, a few steps before we can get them into the exam room.
Yeah. Do you, Dr. El-Khatib, do you feel like contraception should be a bigger effort beyond OBGYNs and specialists, especially in a setting where we serve younger community? Do you think other providers, primary care physicians, family physicians, emergency physicians, psychiatry physicians should be more educated?
Yeah, absolutely. It's a holistic approach, right? So we ask about diet, about exercise, about sexual activity, and it's all part of this conversation. And we don't have to necessarily refer first during the first encounter, but it's something we follow up on during other encounters too. So definitely, it's part of this whole the holistic approach. Education, is always key and empowering and helps the student to grow, not only make informed decisions, but grow in their decisions too. So, absolutely.
I want to close on these two subjects that we've talked about, asking you what are the most common side effects about contraception that no one talks about with patients?
Well, we can start with the most common because that's what they see on social media, but also what their friends talk about, which is a potential increase in weight gain. That doesn't necessarily go across all of the birth control options, but the challenge again that we have around the miseducation and myths is that gets bucketed into everything. Contraception means you're going to gain weight, and even though in that includes, other options that studies are not associating it with an actual weight gain. For example, the non-hormonal ones, but even the IUDs, because they have a different type of hormone. But, it's unrealistic for a non-clinical person to be expected to understand that even within the range of birth control pills, there are different types of hormones that cause different types of potential side effects. So for one person, it could be that this particular brand of pills tends to cause more headaches or more water weight gain than another. So I think that's where things can get a little bit challenging in terms of our ability to express that to other patients. But I think, between the side effects that are most common, then of course the ones that are less common are even less talked about. So we already have this gap between misinformation with the most common side effects. And then for us to even think about the less common ones, such as clots, DVTs or PEs, increase in blood pressure, those are less talked about, and that's a challenge that we face.
Yeah, I think it takes us back. It takes us back to what we've been talking about all this time. The best way to empower patients and young women to make a decision is to guide them as what to ask. So have you asked about all the side effects? But how are they to ask if they don't know that this could be a potential side effect? Like, what is DVT? What is PE? Can I have hypertension if I don't have a family history of hypertension? I'm healthy. I'm 21 years old.
Right.
Otherwise, I exercise. So I think when you don't know the possibilities, it limits what you can, how to advocate for yourself as patients. So I think definitely brings us back to what we've been talking all this time about empowering people to make the right questions when they are in front of their providers. And I think to your earlier point, it's not only the provider's job, but how do we transfer that action to the patient, to the student, to the user?
Yeah, by like when we talk about the motivational interviewing
Yes.
techniques, but also letting the patient know that they are cared for by a team. So it's not only the doctor, like the psychiatry nurse, it's the other provider, the OB gynecologist, by also even the phlebotomist. They're all part of the treatment team. And sometimes I had a patient that was referred to the women clinic, right? For education. Then the psychiatry nurse on the team makes a follow-up call. Hey, were you able to see the provider? How was your... We do that so they know that they're supported by a team, not just one person. So that helps a lot.
I think I want to bring that education consultation to the table, because we make appointments to see our doctors, to treat, to correct, to get better from a symptom or something that we might be experiencing. But rarely do we make an appointment to prevent, and even more rare do we make an appointment to get educated. So I think it's definitely both ways, like the provider having the ability to meet the patients where they are, and the patient having that initiative and the willingness to be educated about the decisions that they're about to make. So I want us to talk about something that's very popular within a higher ed setting and amongst young women and in the younger population, which is emergency contraception awareness. So I want you to tell us about the myths and the pros and cons of emergency contraception.
Emergency contraception, like you said, is very popular now. It's on campuses, or it's not just giving out condoms anymore. It's like giving out emergency contraception to try to promote the awareness, which is great. I think the challenge is that we pass it out, we don't pass out education with it, right? The education around EC is really important because the timing in which you take it for it to be effective is very important. The fact that there are myths around it being similar to an abortion is also incorrect, because this is the method of action of emergency contraception is not in any way related to abortion. And so those misconceptions can be very harmful, even if they have access to it because it's being given out on campus. I think the dangers of EC as well is that we do see sometimes that it's kind of related to reckless behavior. And so if students believe that they don't have to plan ahead and then just take EC, that really does miss the point of what we're trying to provide here. And so that's the education wrapped around the EC is really, really important for students to understand, like, what's the purpose of the EC and what can you do to avoid having to take EC. Is really, a gap in the education.
I think a big statement is emergency contraception is not a contraceptive method per se. It's not your go-to contraceptive method. There's a reason why it's called Plan B. So it should not be what you plan around your sexual activity. And also, it's hormonal. So there's those effects,
Right?
And so side effects.
And so some students will come in and their chief complaint is irregular periods. So we go through our regular questions, and then I've learned over the years to ask, when was the last time you used Plan B, if you have? And so that's often they'll say, oh, I did use it 2 months ago. I did use it a month ago. Well, that explains why there's this new irregularity to your period, and then we go through the plan there. But again, it's something that is not wrapped up in the education around Plan B, but because it is hormonal, it can certainly, impact your period patterns.
Yeah. I want us to close our discussion on the roundtable before we move to Q&A with a call to action, because we've touched so many good subjects here, and we've had so many great concepts coming onto the table. So, what is the role of higher education institutions, government, and policymakers in the public, the general public, and patients in expanding or restricting contraceptive access and education for everyone? Vania.
I think more outreach, and just be on the ground. And workshops can be helpful, events for at least the school community, be present in all the events we can be present and provide one-on-one education and also workshops. Yeah.
I think any systems or health organizations or higher ed that may be listening, making sure, starting with your own student health center and health organization, and make sure that whatever resources that you don't have available for whatever reasons, because of your state or your funding, is to make sure that you have a way to make sure that students and patients can access the other resources. And so if your organization does not offer a non-hormonal IUD, that's fine. Hopefully there's a pathway that you're working on to get that. But I understand there's so many barriers operationally. But then just make sure that you do have a referral system in place so that if that patient wants a non-hormonal IUD, that they have access to get there. Because if we don't have that in place, the patients will just believe that that's the limit of their options and they will stop there. And so it's really encouraging anyone who's listening who's part of this organization that may not have all the resources is to make sure you make it available.
Right.
And yeah, and I was just gonna say, like, again, to your point too, like, just making education around this topic more accessible, and not just the conversation of contraception, but just all of sex education. Like, that needs to be something that we talk more about, and more openly, and without shame and things like that. And then another thing, and I don't know, maybe this is like a big ask, but like making access to contraception like a free or low cost thing, because that is something that is also like the barrier for folks on getting these things. So yeah, like shifting our focus to remove those barriers so folks can just get what they need and hopefully like live safe and healthy lives, So yeah.
We see that a lot here in the community, where someone wants to get a non-hormonal IUD or a hormonal IUD, but they stop at the price point, or they stop because they are uninsured. So they go back to whatever's cheaper.
Yeah.
So that could be oral contraception, or that could be using Plan B as your Plan A. So because it's $7.
Yeah.
So it goes back to the role of legislation and public health institutions. How are you making sure that the prices in which these products are marked are accessible for everyone? Because young women who are in college age, or maybe young women who are professionals who just graduated, have other economical factors. So they might not have $800 to spare on a non-hormonal IUD or something else. How do we break those barriers? How do we keep talking to policymakers about making the access fair and affordable as well? I think that's just such a big component of it and such a big part of it. How much of the variety of the contraceptive methods that we have and the advancements that we've made is limited because of access and because of economical resources that someone may have. All right. Well, thank you. Thank you.
Thank
It was
Thank
great.
you so much.
Thank you.